Hello everybody and welcome to MOSCON e-newsletter. Let me welcome today Dr. Anand Vinekar, who is a pediatric retina surgeon from Narayan Netralaya, Bangalore, and the professor and head of department. Dr. Anand has both a passion and a vision for ROP screening and treatment in India. He is the program director of KIDROP, the country's first tele-ROP screening program. So first of all, Dr. Anand, tell us a little about KIDROP.
First of all, I'd really like to thank MOSCON for this opportunity and thank you for having me here and for those kind words. KIDROP started in 2008 as a telemedicine program to screen for ROP in rural outreach centers in the state of Karnataka. We started with about 3 centers and now the whole state is covered. In the KIDROP program, we have trained technicians, and these can be optometrists or ophthalmic assistants, to take wide field cameras into the rural NICUs, and there they screen the resident babies, and they are taught to read these images on site, and these images are uploaded onto an internet platform for ROP specialists to remotely read them, and babies who require treatment are treated in the rural centers itself.
So Dr. Anand, what do you see as roadblocks to the expansion of this KIDROP program in the country?
With the evolution of KIDROP, we found that other states were adopting our model, and the Government of India in its newest guidelines has said that wide field imaging is probably the best way to screen for ROP in the rural areas, which is and been supported by another report which validates the KIDROP program using the Center for Disease Control guidelines, which says that it is probably better to do an imaging rather than indirect ophthalmoscopy, especially in untrained hands, because of the medico-legal aspects that are involved in ROP today. As we are all aware, the Supreme Court of India passed a very landmark judgment in 2015, which held liable groups of physicians, both pediatricians and then later ophthalmologists, for not providing the standard of care. With this want of screening, expanding the screening program throughout the country, the cost of the camera has become the major roadblock. And for this, there have been some low-cost alternatives that have come up. One such device that we are aware of in KIDROP is a device that was made in Bangalore, and we've been their clinical partners through a Department of Biotechnology or a DBT Government of India grant. This device is probably around 1/6 or 1/8 the cost of the US camera, and we have just completed a multi-centric clinical trial where we've compared it head-on-head with the RedCam shuttle, which is what we've been using in the KIDROP program for over a year. The results are promising, and that was part of my deliberation here at the MOSCON.
So hopefully we would have this device tested and then commercially available, which would help us in expanding this program. Now, one last question, sir. What do you see as the future of imaging in ROP screening?
So some of the, other than the wide field imaging, that when we talk wide field and ROP just for a screening perspective, we are referring to about 120 degrees or 130 degrees. But there is also ultra wide field, which is 200 degrees, which is a camera which is not specifically made for the infant or pediatric population, but nevertheless groups have shown that it is useful in picking up pathologies in the periphery. But what personal experience that we've had is using the spectral domain handheld OCT or the ST-OCT, where we've been imaging these babies even with spontaneously regressed ROP, and we found in them a foveal edema in almost 30% of cases in our cohort of the type 2 ROP which spontaneously regressed. What was interesting in these cases was that even though the edema resolved by the 3rd corrected month, these babies had lower visual acuities when we tested them using teller acuity all the way up to the 1st corrected year. And some groups have also shown that they've had lower neurodevelopmental markers even up to 18 and 24 months. So we believe ST-OCT in understanding subclinical disease and understanding the way preterm retinae actually grow in terms of which photoreceptors come at what corrected age, this is going to really change our concept of how we understand the growth of the retina in an infant or a preterm baby with or without ROP. And one final advance that we've just had some pilot experiences is the dye-less angiography, which is called the OCT angiography, we've been able to use that to test a baby with ROP and found that we were able to map the flat neovascularization in aggressive posterior ROP, and after treatment show that the flat neovascularization not only disappeared at the superficial area where we all know it exists, but also the deeper extensions of these vessels had gone. So I think we are understanding so much more about the way this pathology presents, which we didn't see earlier because there was no way of imaging them, but that's really opened up the new frontiers.
Well, Dr. Anand, I think that was quite an eye-opener, and let's hope and pray that your program that you have developed in your state will soon be implemented at a much larger level in our whole country. Thank you very much.
Thank you.